focusing on interventional techniques for CCLA. All of us should be familiar with the ISPA classification. We are focusing here on the complex lymphatic anomalies, specifically CCLA, more focus on RASopathies. So central lymphatic flow is derived by major inputs from liver, mesentery, and the lower extremities through the pelvic lymphatics. CCLA is when this normal flow is disrupted and dysregulated. How does that happen? With dysplasia or obstruction, you have lymphatic fluid overproduction that produces what we call a lymphatic flow disorder that manifests in various body compartments in potentially very morbid diseases. Chylothorax, classic bronchitis can lead to asphyxiation, chylopericardium, protein-losing enteropathy lead to wasting, chyluria. All of these can be very, very difficult diseases to manage. So these disorders, in my mind, I divide into secondary and primary. Secondary, by sheer numbers, is larger, but we're focusing today on the primary section. And CCLA in particular, the ISPA classification indicates RASopathy is a big component of that, but I also include other entities like trisomy 21, Turner syndrome, Peyer's mutations, and then the other basket terms like primary intestinal lymphangiectasia, chylothorax of the neonate, and other CCLA, not others specified. So that's what we're going to be focusing on in this talk. So we have a patient with this disorder. We first proceed in our service with imaging, and for imaging, 3-point axis MR lymphangiography is our standard, and it has been extremely informative on understanding these diseases. So we have the 3 compartments: hepatic, pelvic, retroperitoneal, and then mesenteric, as you see here on the slide. Excuse me, went the wrong way. So this is how we do it. Dr. Lahi had a few slides on this, but inguinal nodes, hepatic lymphatics, and mesenteric lymphatics are accessed with ultrasound guidance. Confirmed with fluoroscopy, you access these with very small 25 gauge needles, secure them, as you've seen this picture before, and then the patient is wheeled into MRI. In our suite, the MR suite is right next to the fluoroscopy suite, so this transit is pretty smooth, but it can be done if you have some separation between the suites as well. Once in MRI, you have 3 basic sequences to focus on. I'm happy to share these slides. I'm not going to spend too much time on them. First is a heavily T2 weighted sequence that lets you assess the overall fluid distribution, and sometimes you can see the thoracic duct. And then you move on to your contrast enhanced sequences. The dynamic contrast enhanced sequence, which is a time-resolved MR angiogram, allows you to show flow dynamics and sometimes verify the thoracic duct outlet is intact. And then you move on to your 3D spoil gradient echo sequence. It just shows you anatomy pretty well once you've injected the contrast. So just 3 sequences, it's not that complicated. And you will inject a weight-based dose of gadolinium for the patient. And this is what it looks like. First is your T2 weighted image on your left side, and then your inguinal node injection. You should see contrast go straight up towards the thoracic duct. That's normal without any reflux. Moving on, your mesenteric and hepatic injections should look like this. Hepatic injections, once you inject the liver, it goes into mesentery and then into the thoracic duct. It should all go upward. And then your mesenteric injection from mesentery up into the thoracic duct. Again, these are normal MR lymphangiograms. And finally, your 3D T1 graded spoiled gradient echo sequence, and that shows you to better advantage the anatomic detail, gives you very good contrast resolution. So that's our 3rd sequence here. These are all normal patients. So with your MR lymphangiograph, one key aspect you should look at is thoracic duct outlet. I'll get to why that is. That's important in our algorithm of management. You can assess this by injecting contrast into the inguinal lymph nodes and then seeing egress of your ultrasound contrast agent into the varicose-cephalic vein. You can also sometimes find this on MR lymphangiograph also by on your time-resolved MR angiogram. You can see flow into the thoracic duct and verify patency that way. So that's your central lymphatic system, how you assess that. For CCLA patients, particularly peripheral lymphatic assessment is also important, particularly patients with lymphedema, I should say, and that's done with dual contrast techniques. So you give one agent with the iron oxide nanoparticle fermoxetol with your standard gadolinium. You use the fermoxetol to null the signal from the veins, and then after you inject the gadolinium into the web space between the toes, and then follow the contrast up over time if everything goes right, you increase your TE, which is a parameter in your MR scan on the SPGR sequence, and you use that to null the signal from the blood pool. And if everything goes right, you should just see your peripheral lymphatics here. So we'll move on and to discuss particular disorders. So normally you should see normal organized flow, as I mentioned on the MR lymphangiogram. With RASopathy, CCLA, the flow is extremely disorganized. And these two articles just highlight the spectrum of disorders you see with RASopathies. Overall lifetime prevalence of lymphatic flow disorders and RASopathies is about 40%, as you see in this paper. And then this is the spectrum of disorders you get. Lymphedema is the most common, but you can get central lymphatic flow disorders, chylothorax, all the way down to ascites and protein-losing enteropathy, as you see here. So, characteristic central lymphatic abnormalities in RASopathy. Previously, you saw normal MR lymphangiograms. These are decidedly abnormal. Key components: number one, disorganized central lymphatic system with ill-defined thoracic duct, as you see on the screen. Number two, posterior intercostal perfusion, as you see there. And then dermal backflow. You see all of those aspects on not only your MR lymphangiogram, but also on your fluoroscopic lymphangiogram if you end up doing an intervention for this patient. Another component is your retrograde mesenteric flow, which you see highlighted on the bottom arrows in the abdomen. So these are all MR lymphangiogram manifestations of RASopathy. I mentioned that lymphedema is a common manifestation of these disorders. So this work has divided the lymphedema into various categories. Two categories in particular: hypoplasia and hyperplasia. With hypoplasia, you have reduced lymphatic absorption. With hyperplasia, it is retrograde reflux. And we see that on this peripheral MR lymphangiogram here, hyperplastic lymphatic ducts in the thigh here with retrograde flow on the fluoroscopic lymphangiogram. Such a distribution setup is amenable to lymphovenous anastomosis when you have enlarged lymphatics with retrograde flow. Lymphovenous anastomosis will be a potential solution here. So RASopathy is not the only CCLA. As I mentioned, you have a spectrum of other disorders. POs are one mutation, trisomy 21. They have subtle differences in how they appear on a MR lymphangiogram, but the key point is that you just see this cloud of lymphatics, extremely disorganized flow. This is a very informative article on PSO1 and how it determines ultrastructural abnormalities in neurolymphatic valves. So we talked about disorders. Let's move on quickly to intervention. So this is in my mind, a good algorithm. What happens to our patients who present with CCLA: initial multidisciplinary visit in our multidisciplinary clinic. Medical management has often already been instituted, and the initial genetic workup is set. If symptoms are progressive, then they move on to DCMRL, and then further genetic workup and gene characterization. As Dr. Cohn-Cutler indicated, often we hope to get the therapeutic gene identified, sometimes we don't. But then now we decide, are the patient's symptoms severe enough? So these patients will move on to intervention, lymphatic intervention. We aim for success, but sometimes it doesn't succeed. If it doesn't succeed, we move on to a hybrid surgical procedure with Dr. Lai, Dr. Mayeda, as you heard in the last talk. Conjunction with this is, of course, targeted therapy. If we have a gene, we move on to targeted therapy. Sometimes if the symptoms are severe, therapy is empiric. Obviously, if the patient does not have severe symptoms, we just keep on supportive therapy and then continue on vigilant management. Regarding the intervention, we have a patient with severe enough symptoms to intervene on. One thing you should not do is embolize the thoracic duct. So this is one example of a 5-month-old child with Noonan syndrome and massive chylothoraces, underwent thoracic duct ligation and embolization, and this is the outcome 8 months later. Significant increase in flow disorders. You have now multi-compartment disease and very little options in management. So for CCLA patients in a patent thoracic duct, do not embolize the thoracic duct, do not ligate it. That's the key aspect. So this, we move on to specific disorders. As I mentioned, chylothorax, plastic bronchitis. This is our algorithm, very similar to what I mentioned before. First, assess for targeted therapy, and then see if the thoracic duct is patent. If the thoracic duct is patent, initial intervention, percutaneous intervention, and selective lymphatic embolization. If it is not, you have the option of selective embolization and sometimes your hybrid surgical procedure, which I'll touch on. You do also have rare patients who have thoracic duct stenosis or obstruction, which we will treat that. So this is how we do thoracic selective embolization. Embolic agent via microcatheter is injected specifically into the channels that are producing the abnormal perfusion into the mediastinum. As we see here, we have multiple agents like glue or a sclerosing agent that we can use. Sometimes when that fails, we do hybrid procedure with surgery. So this is a lateral thoracotomy with embolization, by needles by the interventionalist, and then argon beam cauterization thorectomy by surgeon, courtesy of Dr. Lahe. We have this one case, a 11-year-old male, had repeated percutaneous interventions that were not successful in getting control, went on to thoracotomy, combined procedure with surgery and embolization. This was how he looked like immediately after procedure. The good news is this time the procedure worked with the hybrid embolization and pleurodesis cauterization, and he is symptom-free over long term. Protein-losing enteropathy, as I mentioned, can lead to severe symptoms and wasting. This is a patient with primary protein-losing enteropathy. How do we treat this? You will hear about this in the next talk. Conjunction with endoscopist, primarily Dr. Brownell, guides us through the procedure to inject periduodenal lymphatics, again with glue or a sclerosant agent. This is how it looks at the end of procedure. And then these are some of the outcomes. You should see normalization of your albumin levels, improvement of dilated lacteals due to mucosa, and then remodeling of the central lymphatic system, especially if they are on a targeted therapy. So this is one case, a patient treated both with intervention and with targeted therapy, following 4 months on the MEK inhibitor, significant improvement in remodeling of the disordered lymphatic system and his symptoms. So this is just a cross-section of patients with primary PLE who had these such interventions, and again, outcomes regarding albumin have been encouraging. Cholestacitis, often what we've seen in our experience, the leak ends up being in the region of Morrison's pouch. You can confirm that with contrast ultrasound injection into the mesenteric lymphatics and liver, and also an MR lymphangiogram. But initially we do just like other cases, percutaneous embolization first. If that does not succeed, we move on to hybrid embolization. This is another hybrid case where we have a patient open, we embolize with direct visualization, and also cauterization. And this, again, in this patient had resolved symptoms on follow-up. Duct obstruction is another case. We don't encounter that much often, but this is a kid with Turner syndrome, had a big lymphatic malformation that was impinging on the thoracic duct. When we treated this thoracic duct with the lymphatic malformation sclerotherapy, the thoracic duct obstruction resolved, and the symptoms also resolved, confirmed by the clearance of gradient. Finally, not all patients get intervention, so this patient, for example, was treated only with targeted therapy, deemed not a candidate for an intervention due to just the diffuse nature of the disease, but we had a gene in this patient, and you can see how symptoms and the appearance of the system resolves, gets better over time. Multidisciplinary management is important in management of these patients. Do not need to stress that with all our supportive services. And then adverse events are possible. On the spectrum runs from abdominal pain all the way to more serious complications. You just have to be very mindful of that over experience. So in summary, multi-compartment MR lymphangiography is where you start. It's essential for evaluation and to guide intervention. Selective procedures are preferred for the cases that go to intervention. Genetic diagnosis is important for therapy, as you heard from other speakers as well. And of course, multidisciplinary management, nothing is possible without that approach. Thank you.